Hi, my name is Madison Gheen, VN53, and I'll be talking about Walker-Warburg syndrome. Walker-Warburg syndrome is a rare multi-system disorder characterized by muscle, brain, and eye abnormalities. The most consistent features are smooth appearance of the surface of the brain due to the lack of normal folding pattern, often with malformations of other brain structures, including the cerebellum and brainstem, various developmental abnormalities of the eye, and progressive degeneration and weakness of the voluntary muscles, congenital muscle dystrophy. Walker-Warburg syndrome often leads to death in the first year of life. However, the specific symptoms and severity can vary greatly from person to person. Walker-Warburg syndrome demonstrates autosomal recessive inheritance with the recurrence risk of 1 in 4 or 25% for a couple who has previously had a child diagnosed with this genetic condition. Signs and symptoms. Some signs and symptoms would be muscular dystrophy and abnormalities of the brain and eyes, like I said before in the introduction. Symptoms of, I'm going to just keep it as WWS, are congenital, so which they are present at birth. And some of the brain abnormalities can be detected by prenatal ultrasound and or fetal MRI in the later stages of the pregnancy. Congenital muscular dystrophy, or a weakening and loss of muscle at birth. Muscle dystrophy causes affected infants to have severe hypotonia, so which is low muscle tone, which might be noted as floppy baby syndrome. Muscle weakness and atrophy typically gets worse over time. Some affected individuals develop abnormally fixed joints or contractures that occur when thickening and shortening of the tissue, such as muscle fibers, and they deform and restrict movement of an affected area. Affected infants usually have a variety of serious brain findings, including lissencephaly, which means smooth brain, hydrocephalus, enlarged ventricles, and malformations in the back of the brain. The type of lissencephaly involved in WWS is described as type 2 or cobblestone lissencephaly. This is because the surface of the brain is smooth and has a cobblestone appearance due to the collection of clumps of brain cells, which are the neurons at the surface. Hydrocephalus, which is characterized by having too much cerebrospinal fluid in the ventricles of the brain, causing the enlargement, can be quite severe and lead to an abnormally large head. Malformations of the back portions of the brain include underdevelopment, hypoplasia of the cerebellum and brainstem. The cerebellum helps coordinate voluntary muscle movements, while the brainstem helps control basic functions such as breathing, salivation, and heart rate. These posterior malformations can involve an abnormally enlarged space at the back of the brain, sometimes referred to as Dandy Walker malformation. So this picture is just showing what the infant would look like with WWS. And this MRI shows that the scans of the brain of the different infants with this disease. And then again, I will talk about the eye situation and how it affects the ocular motor skills. The ocular abnormalities associated with WWS vary widely from person to person, and it can include any of the following: abnormally small eyes, absent or underdeveloped optic nerves, malformations of the fluid-filled space between the eyes, behind the cornea, and in front of the iris, and malformation of the retina, which could cause the retina to become detached. Additional eye symptoms can include cataracts, a cleft or loss of tissue in the retina or the iris, abnormally large and protruding eyes, or increased pressure within the eyes, which is glaucoma. Most of these abnormalities lead to partial or complete blindness. In some cases, infants can see shiny things, or lights or colors, or lights. More signs and symptoms. The brain malformations associated with WWS cause serious life-threatening complications during infancy. Children born with WWS display varying degrees of intellectual disability and often have seizures. The combined brain and muscle abnormalities lead to significant delays in teaching developmental milestones. For example, sitting up, grabbing objects, crawling, and talking, and can be so severe as to cause difficulties in breathing and swallowing. Occasionally, additional symptoms in different body systems could be also be present. In some affected children, urinary abnormalities can occur, causing urinary tract blockage and kidney pelvic dilation, or failure of the testes to descend into the scrotum in the males. Some affected children can have other features such as low set or prominent ears, cleft palate, or cleft lip. So the diagnosis process. Diagnosis of WWS can be suspected via routine ultrasound and or fetal MRI during the late stages of pregnancy and confirmed at or shortly after birth following thorough clinical evaluation and identification of characteristic findings that might require a variety of tests, like I had said before. Genetic testing can be done in an effort to provide molecular confirmation of a clinical diagnosis of WWS. Genetic confirmation occurs when two mutations are identified in a known causative gene. Genetic testing can be done in a variety of ways. One genetic testing method is the sequencing of a single known WWS gene. It could be done if one particular gene is suspected. It is also possible to test for multiple known WWS or CMD genes at once via a multiple gene panel test. Another genetic testing method is called the whole exome sequencing, in which every known gene can be analyzed for mutation all at once. Genetic counseling for families can help their understanding of autosomal recessive inheritance, the current and ever-changing state of genetic testing for WWS, what the results of the genetic testing for the family mean, and the impact of this information on the individuals in the family, specifically the parents. If the affected individual is of Ashkenazi Jewish descent, the FKTN gene should be tested first, since a specific mutation in this gene is common in this population. Otherwise, there is a significant overlap of symptoms caused by mutation in all known WWS genes, so it is difficult to determine a specific order for genetic testing. Some treatment and therapies for someone with WWS. There's no cure or treatment per se for WWS, but management is generally only supportive and preventative. Individuals who develop seizures are typically treated with anticonvulsants. A few children require surgical procedures such as shunting for hydrocephalus or correction of encephalocele. Sorry, that's a long word. Encephalocele, thank you. Some children take phenobarbital in liquid form or crushed tablets to help with the seizures activities. Physical therapy can also be offered to facilitate development or preventing worsening of contractures, although its efficacy has not been established. Feeding needs to be monitored, and supplemental nasogastric or gastric tube feedings provided in some cases. And a detailed eye assessment is also needed. Some surgical interventions. A few children require surgical procedures such as shunting for hydrocephaly or correction of encephalocele. Like I said, a lot of these overlap. Some patients may endure glaucoma and require surgery to help relieve their pressure. Ventriculoperitoneal shunt, which is a medical device that relieves pressure on the brain caused by fluid accumulation. Encephalocele repair, which place a protruding part of the brain and the membranes covering it back into the skull, and it closes the opening to the skull. Ventriculostomy, which is a neurosurgical procedure that involves creating a hole or stoma within the cerebral ventricle for drainage. There's also cleft lip repair, cleft palate repair, and the typical surgical procedures usually require general anesthesia. So this is what the shunt looks like. It's just relieving pressure from the ventricles, and it's just a little monitor right under the skull. So now I will be introducing my mother as my real life scenario / story. This story is very near and dear to my heart, which is why I chose it. So I'm gonna ask her a couple questions and then go from there. So how many children have you had in total?
Hi, my name is Jessica Gheen. I am Madison's mom, as she said. I have had 6 pregnancies, and 5 out of 6 of my pregnancies were affected with the Walker-Warburg syndrome.
And did you find out at birth, or did they tell you during your ultrasounds, or how did you find out the diagnosis of your
First pregnancy was undiagnosed. I found out there were some abnormalities. First pregnancy was a female. I found out at 25 weeks that she had abnormal ventricles in her brain, that they were more lemon shaped than regular ventricles. They were dilated. And so with the level 2 ultrasound, they saw that, she would most likely need some type of intervention and or brain surgery as soon as she was born. However, at 36 weeks, I went into labor, and she ended up being stillborn. When she was born with no covering on her brain. So the skull did not develop, and so it looked like a smash basketball. And so she was 36, almost 37 weeks in utero.
And then after that, how much time in between each pregnancy was it?
Between the first and second one, it was a year, maybe a little under a year. She was born February 14th, 1994. The next pregnancy, Timothy, was a male with an encephalocele protrusion. He was diagnosed a little early on, whereas now I was able to see a genetic doctor to find out, because the first one, they said, it was just a fluke accident, or they didn't know why what had happened. So we didn't decide to do any autopsies or any type of more
genetic testing
or procedures to see what was going on with her. However, so the second one, since it was back to back, and it was a male this time, and it was a lot worse than the first, Stanford wanted to do an induction at 23 weeks. So an induction was done because they were more afraid of my health and safety. If my uterus were to break or have any of the fluid leak into my sac, all the brain matter was in the uterus and
the placenta.
The sac, yes.
And then third was my brother Noah. I'll have you explain that.
He was diagnosed with having dilated ventricles at the 20th week. Between 18 and 20, they did an amniocentesis and saw that it was abnormal. We did a level 2 ultrasound. We saw the ventricles dilated. We took some more testing. But we did not know the actual findings of Walker-Warburg syndrome until he was born. However, in utero, they did let me know that his head was going to be larger than normal, that I would end up having to do a cesarean section because I was going to be cut larger than a normal cesarean because of the size of his head. So that was a scheduled C-section at 39 weeks.
And like I said before, a lot of infants don't live past maybe up to a year of age, but he lived till he was 3 years old. And so the baby after him was me. Like I said it before, it's 1 in 4 babies, 25% chance of one being coming out without the without being affected. So that was me. But the doctors still put my mother at high risk still because they didn't know whether I was affected or not. Just because the way the pattern was showing. So they advised her to abort me, right?
Mhm.
They advised to abort, but luckily they didn't. So again, she was put into high risk, and I came out like this, fine, I guess. And then after me, how
And after you, 2 years later, we tried again, and a female daughter was again diagnosed with the same thing due to the dilation of the ventricles and the amniocentesis. So we decided to do a early termination, just my husband and I going and do an induction, and knowing that she was going to be stillborn at 26 weeks. She looked normal. Her head did develop, the skull around it did develop, and she looked like she was just asleep. But we know and saw the internal ultrasound that her ventricles were dilated, and she was gonna have the same symptoms as our son Noah, which the one that lived till 3. He had severe seizures and had the shunt put in his brain, and also the shunt put in his eyeball for the pressure of the glaucoma. So and that was called microphthalmic eye. And then after that, we tried, well, it was not planned, the last one, but we know that it was also affected in 2006, which was my last one. And that one, I was a little older, and my body was not able and strong enough to go through the whole thing. And so my husband and I decided just again to go into the hospital and do a procedure. And so that we did on our own. And so since my husband and I, we found out that through genetic counseling and study at Stanford University, that we carry the same recessive gene. As if we were related. We have no relation at all. My husband comes from a Caucasian Spanish background, where I come from a Mexican American background.
and so my brother Noah was fully handicapped. He had a nasal gastric tube placed, right?
Until
Don't-
they placed the G-tube.
Until they placed a G tube, but his diet, there's no really set diet, rather than a soft mechanical diet. So he was a feeder. So like I said, like infants do have difficulty swallowing and feeding. So but he liked his food a lot. The only allergy he had was ketchup, right?
Ketchup and raw eggs.
Oh, raw. I don't understand the raw eggs. But to this day, like, we still celebrate the lives of each child every birthday. Although I never had the chance to meet them, I still understand, but that's the way life goes, I guess. My mom, she did start helping
Infant loss.
infant loss
Hospice work.
and hospice work.
Grief.
Sorry, I didn't mean to cry.
Grief support.
And grief support. So it's very touching. But yeah, so here are some pictures of my brother Noah. You can see his enlarged head a little bit. He had a big forehead. That's with my dad. And you can see the difference in the size of his eyes right there. He was always alert, based on what my parents told me. He liked Disneyland. He liked the sounds, music, and this is him again, with his one of his eyes open. Again, you can see like the little drippage of his skull in the back, where the shunt is. There he is again right here, again with the head, and you can also see the absence of muscles in his arms and his legs. And this one again is just a closer picture of his eye. And then this is my mom with him as a newborn. And then again with his eye, you can see it very well right there. It's a very clear picture. And then these are my resources. In conclusion, this is a very, very rare disease, but now that there's more education on it, there's not a whole lot of advocacy for it unless it happens to you or your family or somebody you know. But yeah, thank you.
How long was it?